This presentation, we will focus on a simple but essential principle. Not every unusual or dramatic event in childhood is epilepsy. Children may present with episodes that look frightening, brief, and seizure-like, but the correct diagnosis depends on careful event identification, thoughtful interpretation of EEG findings, and a willingness to reassess when new information appears. Our goal is to review 6 common diagnostic pitfalls and the practical habits that help clinicians avoid mislabeling, unnecessary treatment, and missed serious conditions. Next slide, please. The first step in evaluating a possible seizure is to start with the event itself. A seizure diagnosis should not be built from a test result alone. We need to describe exactly what happened before, during, and after the episode. Then we correlate the history, semiology, neurological examination, and EEG findings. Finally, we reassess the working diagnosis when new evidence appears. These 3 actions, describe, correlate, and reassess, form the clinical discipline that runs through the entire presentation. Next slide, please. Many paroxysmal events in children can resemble epileptic seizures. Syncope, breath-holding spells, tics, migraine, sleep disorders, and psychogenic events may all create confusion. This is why the event history is so important. We should ask an eyewitness to describe the episode in detail, explore the chronology carefully, and request a home video whenever possible. The diagnosis should be assigned only after the pattern of the event has been clearly understood in its clinical context. Next slide, please. EEG is a powerful tool, but it supports the diagnosis. It does not make the diagnosis by itself. A normal EEG does not exclude epilepsy, especially when the recording is brief or does not capture sleep or the event of concern. At the same time, abnormal EEG findings may occasionally appear in children who do not have clinically compatible seizures. The key question is whether the EEG finding truly explains the observed event. When the EEG and the history do not fit together, we should return to the clinical story rather than forcing the diagnosis. Next slide, please. Another important pitfall is overcalling benign pediatric EEG variants as epileptiform activity. Children's EEGs contain age-related and sleep-related patterns that may look sharp or unusual, but are not necessarily pathological. Misinterpreting these variants can lead to a false epilepsy diagnosis and unnecessary medication. When a pattern is uncertain, it is better to review the study with an experienced electroencephalographer, consider repeat EEG if needed, and interpret the waveform in relation to the child's age, state of sleep, and clinical presentation. Next slide, please. Clinical correlation is the deciding test. This means more than simply adding a phrase to an EEG report. We need to ask whether the event semiology, EEG pattern, and clinical context tell the same story. Do the timing, movements, awareness, recovery, and examination findings make physiological sense together? If the pieces do not fit, the mismatch itself is important information. It may suggest a non-epileptic event, an incidental EEG finding, or an incomplete history that needs further clarification. Next slide, please. Now we shift from the risk of overdiagnosis to the opposite danger, missing a serious seizure state. Non-convulsive status epilepticus may present without obvious convulsions. A child may appear confused, lethargic, behaviorally changed, or persistently less responsive. Subtle signs such as eyelid twitching, lip smacking, or small repetitive movements may be the only visible clues. When a child has unexplained and persistent altered mental status, urgent EEG is essential, and treatment should follow promptly when the diagnosis is confirmed. Next slide, please. Premature closure occurs when the first plausible diagnosis becomes fixed too early. Once this happens, clinicians may stop looking for alternative explanations, even when new evidence does not fit. A changing event pattern, poor treatment response, atypical clinical course, or persistent mismatch between the history and EEG should reopen the differential diagnosis. Reassessment is not a failure. It is a core part of good clinical practice and helps protect children from both misdiagnoses and unnecessary treatment. Next slide, please. A repeatable checklist can reduce diagnostic error. Before assigning or continuing a diagnosis of epilepsy, we should confirm that we have obtained a detailed history, an eyewitness account or video when available, careful event semiology, relevant medical and developmental history, and a neurological examination. EEG should be appropriate to the clinical question, and differential diagnoses should remain visible. Just as importantly, follow-up should be used as diagnostic evidence. We should document not only what supports the diagnosis, but also what still does not fit. Common mimics become easier to recognize when we examine triggers, sequence, duration, responsiveness, and recovery. Syncope may be associated with posture, prodrome, and pallor. Breath holding often follows upset or pain. Tics are usually brief, repetitive, and sometimes suppressible. Parasomnias relate to sleep timing and incomplete recall. Migraine aura often evolves gradually with sensory or visual symptoms. Psychogenic events may show variability and depend strongly on clinical context. The goal is not to memorize every mimic, but to identify which diagnosis best explains the complete event. Next slide, please. To conclude, the safest approach is to describe carefully, correlate thoughtfully, and reassess openly. History and video often provide the most decisive evidence. EEG must always be interpreted in context, because neither a normal nor an abnormal study stands alone. Follow-up, clinical change, and diagnostic mismatch should be treated as invitations to reconsider. A systematic approach helps distinguish epileptic seizures from lookalikes and supports the right diagnosis and treatment for every child. Next slide. Thank you for watching. This presentation has been prepared from Professor Mohammadi's teaching archives. I appreciate your time and attention, and I hope these practical points help strengthen diagnostic reasoning in children with possible seizure-like events.